everyone, and welcome to our live session today. I will be going over a quick starter presentation to welcome you all and introduce you to our program and the various opportunities if you have, of course, not attended previously any of our shadowing sessions. PreHealth Sharing, I do want to highlight, is a student-led, minority-led, women-led nonprofit dedicated to helping prospective healthcare professionals gain access to educational resources, no matter the demographic status, abilities, or location. My name is Jesus. I am the Chief of Program Planning here at PHS, and I want to thank you all for attending today. Now, let's get started. There we go. Okay. Just a little PSA, we do have closed captioning for all of our sessions to accommodate all students. This setting is available on the bottom of your Zoom screen. And if you need any assistance enabling the transcript, please direct message one of our team members. We are always looking for ways to be more inclusive and ensure our sessions are accessible to everyone. So please, if you have any recommendations whatsoever for how we can improve, you can definitely email us at info@prehealthshadowing.com. So, since this is an international program, we want to know, where are you guys Zooming from today? You can drop it in the chat to let us know. Oh, we have some, okay. I love it. We have people from all over, from the US, outside the US. Thank you guys so much. I myself, I'm calling in from Puerto Rico and the Caribbean. So if you want to stay in the loop, you can follow us on social media. We are active on both Instagram and TikTok, or you can also sign up for our email list on our website to never miss a session. And we do have some wonderful opportunities for you all as benefits of being part of our program. And if you were looking to get research experience, I am excited to announce that PreHealth Sharing is launching a research program that will allow students to connect with principal investigators as they conduct research in a plethora of topics, fields, and locations. This program is, of course, 100% remote, which means you have the power to connect with absolutely anyone. For more information, you can fill out the interest form that was sent in the chat below, and we will get back to you as soon as possible with any additional details. We have also partnered up with Kaplan to get our students a 10% discount code that can be used on all Kaplan products, as well as free resources such as study guides to help you prepare for your standardized tests like the MCAT, the NCLEX, or the PCAT. If you fill out our short survey in the chat, we will get you signed up for these deals for free. Oh, I'm sorry. And we would also like to draw your attention to another amazing program, that being Neolith. Neolith is an online mental health platform for students. For PreHealth Sharing, for pre-health professionals especially, we note that the path isn't easy, and that is why we have partnered with Neolith to spread the word and offer free access to their services if you use the link in the chat or enter the code PreHealth when signing up. Additionally, we are really excited to announce that we have partnered up with Krispy Kreme for you to purchase one delicious dozen donuts to enjoy with your loved ones. With a donation of $10, you'll be able to receive your treat while also helping us here at PHS. More information and instructions can be found by clicking the link that was sent in the chat. Mask for Mask is another amazing women-led organization that donates 4 masks for every 4 masks sold. These go to people in need during the COVID-19 pandemic. For example, those in the homeless community, healthcare workers without their proper PPE, and others who are struggling to stay safe. With our discount code PHS15, you can get 15% off your order. And if you buy through this method, PreHealth Sharing will also get 10% of the proceeds, which is amazing because, as I mentioned earlier, we are a nonprofit that runs solely off of the support of our community. If by any chance you want to play a bigger part in supporting PHS, we would love for you to be part of our network of student volunteers and team members. You can apply to be part of our administrative team and lead students in various projects and initiatives with professional outreach, grant writing, and much more. We understand that as a pre-health student, you may not have time, so we also offer the opportunity to volunteer asynchronously with tasks that can be done on your own time. We would love to have you be part of this program and contribute your own unique perspective. And wonderful news, if you are a high school student and you want to get involved, we have started a program called HTP, or High School Training for PHS, which allows you to connect with college pre-health programs, get involved in fundraising for PHS, and organize resources for other high school students that are also interested in medicine through pre-health sharing. Here at PHS, we want to recognize the hard work of all of our students in the program. So if you are interested in getting published, you can submit essays, reflections, research papers, and reviews to our editor-in-chief through the link dropped in the chat to have your work on our website. This will look great on CVs, applications, resumes, etc. So do take advantage of it. Also, part of our mission at PHS is to promote diversity. And in order to do this, we have launched an initiative to have monthly panels to celebrate different demographics in the field of medicine. Some of these upcoming events include a series on patient experiences, a COVID-19 roundtable, and an international student forum. If you have a mentor, professor, or professional that has inspired you in any way, and you think they could contribute to these conversations, please nominate them today using the link that was dropped in the chat. And if you can, we humbly ask that you donate to our program. As you know, pre-health shadowing is completely student-run, and we are working around the clock to keep this free and accessible to everyone. Unfortunately, Zoom and our website are not free, so any contribution you can give would be greatly appreciated. If you are not financially able, we request you send this link to someone you think can, so we can continue to support those who cannot afford similar opportunities. Throughout this session, we encourage you all to drop any questions you may have for the speaker in the chat. Our team members will be making note of these to be asked in the latter half of the session, that being the Q&A session. Also, I want to encourage you all to take really good notes as our professional is going over their presentation, as there will be the chance to take a post-shadowing assessment to verify your virtual shadowing hours. More information will be available on this at the end of the session, so stay tuned. Lastly, if you can, we request you turn your cameras on. This is by no means an obligation, as we are respectful of different circumstances, but it does help us feel closer together in a time when socially distancing is mandatory. We also request that you make sure to mute yourself, as this will ensure the professional has the complete and full attention from the audience. I appreciate you all for listening, and now I would like to welcome our professional, Dr. Patel. Thank you so much for joining us today. You may share your screen whenever you are ready. I will stop sharing mine.
Thank you. Thank you for the introduction.
You're welcome.
Hi guys, I am Archana Patel. I'm a physician assistant practicing in Hawaii. I am currently working full-time in urgent care, and so we're going to be talking a little bit about urgent care and going over some a case study as well as some other cases, and then a little bit about my background. I graduated in 2018 and went on to practice in the military first. That's what my first job was, as a locum tenens provider in the military, and then I did sleep medicine for a year and a half before going into urgent care, and I've been practicing urgent care for over a year now. So let me share my screen here. Does that look okay to everybody?
Yes.
Perfect. Okay. So again, urgent care, and then I'm a pre-PA mentor as well. You guys might have seen me on Instagram. AP the PAC is my handle. So there we go. Okay. So yeah, a little bit about me. I grew up in Georgia. It's the only place I've ever lived in the United States before moving to Hawaii. I've moved around for school and stuff, but Georgia's always been home. Multilingual English, Gujarati, which is my native language, and Spanish. I did my bachelor's in undergrad from Armstrong Atlantic State University. I did a bachelor's in biology with a minor in Spanish. If you guys are in a phase of your life where you're deciding what to do for undergrad, highly recommend taking a second language, specifically Spanish, if you're planning on practicing in this country. It's a huge help to know a second language in healthcare, especially. And Spanish is a great language to know, especially here. So I definitely encourage it. Um, my pre-PA patient care experience. So what I did, and we'll talk about the requirements for PA school a little bit, but basically you have to have some patient care experience, hands-on experience before school. And I was a pharmacy technician to gain that experience. And I worked as a pharm tech during undergrad. I applied to PA school, and when I didn't get in my first time, I said, okay, what can I do differently to get in the second time? So I went to Purdue. I did a 1-year master's program in biology. It's not necessary by any means to get into PA school. It is very stressful, but it did get me to where I wanted to be. So after graduating from Purdue, when I was applying to PA school, I was a research assistant at the Indiana University School of Medicine. We were in the immunology lab, and we studied wound healing on diabetic mice with MRSA. So fast forward to PA school, I went to South University in Tampa. I was president of my class. I graduated in 2018. So being president of my class was one of the best things about being in PA school, because one, you get to know your classmates. Two, you get to kind of lead, just kind of organize different things like we did, fundraisers and things like that. And with one of the, I would say the coolest fundraiser that we got to do was working at a concession stand. So we were right by Raymond James, where the Tampa Bay Buccaneers play. So we worked at one of the concession stands during the Beyonce concert when I think it was she was there in 2016. So that was really cool because we really got to know each other when we were under like a high stress situation. It was a lot of fun. Highly recommend getting involved. No matter where you go to grad school, I highly recommend getting involved in your executive board. It helps you kind of find it's a good outlet outside of your academics, because there's this notion that everything has to be about school when you're in grad school, and that's not true. You're still a human outside of school, so just keep that in mind. Again, practicing for, I guess I haven't updated that, but yeah, a little over 2.5 years now. Did adult medicine on the military base. So I didn't see any pediatric patients, and I didn't see any retired military. So only active duty. Most of what I saw there was orthopedics. And then since then, I've done a little bit of pediatrics. I helped last summer for a doc that just needed someone temporarily. But that was a good experience. And then sleep medicine, something that I still do a few days a month. And then currently full-time urgent care. AP the PAC is my pre-PA mentoring service and platform. I do also do what you guys are doing here, which I really appreciate what you guys do, because I think it's such a big thing to have accessibility to shadowing and broad exposure to a lot of different fields. For me personally, I'm biased towards the PA profession. My virtual shadowing is only PAs, right? So I do appreciate that PreHealth shadowing, allows you guys to get a really broad exposure on a global scale. I think it's really important, especially during COVID, when hopefully we're moving in the right direction out of this pandemic. So pharmacy tech, for those of you who aren't familiar, we fill patient prescriptions as ordered by the provider and under the pharmacist supervision, educate patients on programs that are available for medication maintenance. So, if a medication is super expensive, Walmart has like their $4 generic 90-day plans, that kind of thing. So just helping patients get the best deals for their medications that they'll be taking long-term. Insurance companies, they never leave you if you're in healthcare. So a lot of working back and forth with insurance companies to get medications covered, educating patients on how to use their medications and what they're used for. And this is obviously within your scope of practice as a pharmacy tech. You're not the pharmacist. You don't give formal medical advice, but within your scope, there's certain information you can relate to the patient. I would say the most rewarding thing about this, besides working with the patients, was learning the medications, their brand and generic names, their dosages, what they're used for, pharmacology. If you talk to most people in a grad program in medicine, will tell you pharm is one of the hardest courses. Pharm was still very challenging for me too, but I wasn't starting, at ground zero like most of my classmates were, because I was familiar with a lot of the medications. And you do gain exposure to part of the patient care experience, right? You get the part of the patient that is post-medical provider. So what is a physician assistant for you guys who are not aware? Super common interview question. And obviously by then you should be able to answer this, but a PA is an advanced practice provider. So we essentially function the same as a physician to a lesser degree. So we obtain patient histories, we perform physical exams, we order and interpret labs and imaging, we create treatment plans, and we prescribe medication. So we can also perform minor outpatient procedures, as well as being typically we're first assists in the operating room. We're trained as generalists, from pediatrics to geriatrics. So we treat everyone. Depending on the setting, you may not have to treat all that entire population, but we certainly are trained to do so. And we're versatile in the sense that when you get out of PA school, it's a 2-year program, but when you get out, you can go in and look for a job. You take your board exam, become certified, and you can get a job in whatever specialty you want to get a job in, right? So the versatility is the fact that when you join one specialty, today I'm in urgent care. Tomorrow, if I wake up and decide to do cardiology, all I have to do is find a cardiology practice that's hiring a PA or would like a PA, and the training from there is on the job. I haven't had intense cardiology, right? I mean, urgent care gives me some of it, but the most cardiology background that I had prior to that was when I was learning it in school. So the on-the-job training is pivotal for PAs, but it's also what makes us versatile because we don't have to go through residency programs and all of that to change specialties. And that was one of the biggest trying points for me in becoming a PA. There's autonomy and collaboration with the supervising physician. So I currently practice by myself in the urgent care. There's no other provider with me. I've never practiced with my supervising physician like in the building with me. That's also dependent on the state guidelines. In the state of Hawaii, my doc has to be a phone call away. So he doesn't have to be, physically in the building or even within a certain radius of anywhere that I'm practicing. I just need to be able to reach him if I need him. So that's kind of the autonomy and collaboration. As a PA, with the laws where it currently stands, and this is definitely changing, there is a push for independent practice, getting to basically get rid of the requirement of needing a supervising physician. I definitely think PAs are capable of that. I think we're a little ways away from having that, but I don't feel like I am, working under a physician at any time. Your clinical judgment is your own, and if you need help, just as a physician would, you do have to realize that you need help, and you need to be comfortable asking for help when you need it. And then PAs are super instrumental in bridging gaps between the medically underserved and quality medical care. So this is my PA school class, and we can never get a perfect picture because that's just who we've always been as a class. And so this is our graduation day. And so my why did I go into medicine? So I had a cousin that had a brain tumor, and he was kind of my inspiration to go into medicine. A lot of unknowns surrounding his condition. He ultimately ended up passing away, but that's kind of what triggered my interest in medicine. And then I didn't really know what I wanted to do. I was already a pharmacy tech, but I knew I didn't want to become a pharmacist. So I was just exploring my options, and I personally ended up in the ER with appendicitis, and I was cared for by PA. So that was my first introduction to the profession, and I realized that the versatility is the first thing that caught my eye, because he was a family medicine PA, but he was practicing in the ER because he could, and so he just took a few shifts a month. I happened to be one of his patients one of those nights, and so that's what kind of intrigued me about the PA profession initially, and then I shadowed and obviously learned more about the profession and how different the profession is based on the specialty. And then creating my platform, this came out of kind of hiding, I guess, after a while due to COVID. So during COVID, I've always, as a practicing PA, I've always had, I have a passion for teaching, and I've always had that. And so when I was initially practicing, when I first started, I always had shadow students or like pre-PA students or even high school students who didn't know what they wanted to do and just shadowed for like a day or so. That completely stopped during COVID. And me being a second-time applicant, and knowing that there were some things that held me back from getting in the first year, I didn't want shadowing to be something that held other students back in these coming years, especially because of COVID, and in-person shadowing, as most of you guys probably know, was completely halted. And so that was initially why I created the platform. I was just bringing other people on to virtually shadow. And then from there, it just kind of grew into what it is today. So PA school admissions, for those of you who aren't familiar, for your bachelor's degree, that's the first thing you have to do. You can do it, you can have a degree in any field, any specialty. It doesn't matter what you do your bachelor's in. You can do business if you want. You can do English, you can do arts, doesn't matter. You just have to complete all the prerequisite coursework for the programs you're interested in. So every program, and 90% of programs have the same courses, right? Anatomy and physiology, bio 1, 2, chemistry, organic chemistry, that kind of thing. So that's what I mean by prerequisite courses. So all programs have their list of prereqs on their website. And you just have to make sure that somewhere throughout your bachelor's, or even after, some people take the couple years after their bachelor's degree to complete these prereqs. Doesn't mean you have to get it done during your bachelor's, but that's what you have to do in order to be eligible. And it's usually, PA school is usually 24 to 27 months. Some are 30-month programs too. And there are direct track programs. So if you're in high school and you know you want to be a PA, there are programs that are 6 years. So you go from high school straight to an undergrad that already has a PA program track for you, and you just meet their, it's structured to guide you towards the PA profession. And the last 2 years will be in the PA program directly. So you don't have to go through that entire application process. But the give with that is, obviously you have to know that this is what you want when you come out of high school. Apply early the year you apply in April, the year before you plan to start. So the students that are applying right now, the application opens end of April every year. The students that are applying right now will be starting in 2022. Some programs do start in January. So my program, for example, started in January. So but they'll be applying for that. And the application is called CASPA. It's a Central Application Service for a Physician Assistant. The healthcare experience that's required is referring to shadowing experience, virtual and in person. A lot more programs, because of COVID, are accepting virtual shadowing experience. So that's been nice. And then of course, in person, nothing really replaces in-person shadowing. Patient care experience. So having like a direct hands-on experience taking care of patients. So medical assistant, EMT, the examples that I have here, those are generally well accepted. Medical scribe, for some reason, has been up for debate recently. I'm not sure why. I personally think medical scribe should be counted as patient care experience, but it's not always. Emergency room technician is another one on here that is counted usually. And then you need letters of recommendation from various providers or professor advisors, and this is based on the school. They'll tell you, what you need. And then personal statement, of course, is your why. Why do you want to become a PA? It's your essay, and it's you on paper, right? I mean, everything else is pretty objective as far as your grades and all of that stuff, but this is your statement. This is you sharing why you want to become a PA, which is something they're not going to be able to find anywhere else. So you have to make it count. The GRE is the exam. There is now a PA CAT. So that is something that's going to be coming on. A lot of schools are probably going to start requiring it. It's the MCAT equivalent to PA school, basically, because right now the GRE doesn't have sciences. There's English, reading, and math, or writing, verbal, and math, I should say. And but the PA CAT is ultimately going to replace that in the years to come. Resume, of course, supplemental essays, volunteering, leadership, awards. So a lot of programs look at you as a whole applicant, like it's multifaceted there. And then the PA school interview, obviously, just be yourself. That's the biggest thing, right? They already know you because you've already sent all your application stuff in. The last thing left to fit this, the last piece of this puzzle for the program is just getting to know you, right? Are you capable? Are you personable? Are you able to get along with other people? That kind of thing. Super straightforward. So a day in the life of an urgent care PA. Typically work about 14 shifts per month. My contract is for 14 shifts. I personally usually work about, I would say 16 to 18 days a month. And then I do 3 or 4 days in sleep medicine. And then 12 hours each shift. So that's my company's structure. Not every urgent care is the same way, but I do 12-hour shifts. So we work 8 to 8. Sometimes, like on Monday, I'm flying out, so my colleague is going to cover half my shift. So we can swap within each other however we want to, but that's typically how we're scheduled. Broad scope of practice, because any specialty, any complaint. If you guys have ever been to an urgent care is kind of, the way I explain it, it's in between your primary care, your family medicine doctor, right? And then the emergency room. Maybe you're not sick enough to go to the ER, but you also don't feel well, so you don't want to wait to have, be scheduled for an appointment, because our urgent cares are all walk-in. So that's kind of what an urgent care is. No 2 days are the exact same as a result of that. Some days are really slow, some days are really busy. The highest number of patients I've seen so far in a day has been 39, which is actually not that busy compared to a lot of our other clinics. And there's only one provider in each of our clinics. So one doc or one PA. There's 2 PAs in our group. There's 19 providers total. Non-procedural things that we do, just examples: rashes, ear infections, chest pains, right? And again, your decision as an urgent care PA or urgent care provider in general is, does this person need to go to the emergency room, or can I send them home and either do a close follow-up, or can they wait for their primary care appointment? That's probably the most stressful part, no matter what the complaint is. Procedures that we do, for example, IV placement, usually hydration. I don't do IV medications. If I feel a patient needs IV meds, that's an emergency room or hospital, being admitted type of deal. So IV hydration, though, pretty common. We don't have nurses in our clinic. We have nurse managers that kind of oversee our clinics, but no nurse that actually staffs the clinic. So, and that's not the same in every clinic. Some clinics are staffed. Some clinics are staffed with nurses as well, but we aren't. So it kind of like forces us to keep our skills up to date too. So placing IVs in PA school, you learn, oh, you'll have a nurse to do it, so we're learning it, but you'll always have a nurse. Not true. We don't always have a nurse. We do incisions and drainages. So abscess, right, or like a cyst or something like that. We do cut and drain those. We do laceration repairs. We do stitches, sutures, and staples. If it's in the scalp, we typically do staples. Everywhere else, pretty much, we do sutures or stitches. Nail removals, right? Ingrown toenails, infected toenails, draining toenail abscesses. We also do splinting. So if you have a broken bone, we can do a temporary like fiberglass splint in the clinic. So there's a lot that our urgent cares do. Point of care testing, meaning the test that you can get the results for right away. We do COVID testing, but we swab and we send our sample to the lab. We don't do rapid testing. So COVID tests usually come back in 24 hours. But point of care testing, we do rapid strep tests, rapid flus, urinalysis for like a urinary tract infection, HCG testing for pregnancy, right? And monospot testing for mono. We also do H. pylori, the bacteria that causes stomach ulcers. Things like that. And then workers' compensation, MBA, those are my least favorite because they take a long time and there's a lot of paperwork, but we do them. So MBA is motor vehicle accident. Medication refills, bridge therapy only. Again, we're not primary care. So a big part of what I do in the bottom there is patient education, because patients don't realize, not every patient, realizes that in urgent care isn't the place to get your medications refilled, because a lot of times I'll ask, did you talk to your primary care? Did you reach out to them? And the answer is no. So I really encourage patients to, I tell them like, I can give you a bridge therapy, like a couple of weeks worth, but for future refills, I won't be able to refill it for you. You need to see your primary care for that. So go ahead and schedule an appointment. So that's one thing that we do. I just don't prefer that. And then order outside labs and imaging as necessary. But one thing my medical director is really good about is reminding us that, you know, when we're ordering labs and imaging outside, you're kind of going into a primary care thing unless you absolutely feel like it's going to change the patient's outcome. So for example, if I'm thinking a patient has like a kidney stone, I can order an ultrasound, try to get a same day ultrasound, call the outpatient imaging services on the island, see if somebody can squeeze the patient in for a same day ultrasound. Sometimes they can. If it's early enough in the day, you can sometimes get those imaging, right? The modalities. But if they can't, does this patient absolutely need to have this ultrasound today? If they do, and you can't get it outpatient, send them to the ER, right? But in most cases like that, if you're trying to schedule outpatient, that patient, if that means if you want them to have it right away, they probably do need to just go to the ER. So my medical director does try to say, you know, just think about whether it's going to change the outcome. And I think that's definitely helped me practice just more, I wouldn't say like minimalistic, but definitely more, I'm more cognizant versus just ordering everything, right? Because you feel like you need to cover yourself. So that's always a good reminder. So here's our case study. 28-year-old female. I had this case in, I want to say it was October of last year, October or November, but 28-year-old female comes to the urgent care clinic. She has abdominal pain and is concerned about a urinary tract infection. Pretty straightforward. Vital signs, blood pressure, 128/84, respiratory rate, pulse, you know, everything looks good. Her last cycle was October 30th, 2020. So yeah, I must have seen her. I think it was like a week after this. And her pain scale is a 7 out of 10. It's right lower abdominal pain. Current medication, she's just taking ibuprofen for the pain, helps a little bit. No known allergies or drug allergies. No past medical history and no surgical history. Subjective data, the HPI, when you're looking at like a patient's note, HPI, history of present illness, is the subjective data. It's what the patient tells you and their symptoms. So you get a sudden onset. She had a sudden onset of sharp cramping, abdominal and pelvic pain, 7 out of 10 since 3 p.m. that day. I saw her around like 6:30 or 7 o'clock. Associated symptoms include nausea, vomiting, cramping. Hematuria means blood in the urine. Dysuria means discomfort or pain with urination. And then spotting for about 2 weeks. She's been spotting. Her OB-GYN was aware of the spotting as well. She came into the urgent care clinic because she had a really bad UTI in January that she was hospitalized for, and she feels like it's the same thing. No new sexual partners, no chance of pregnancy. She's not on birth control, no history of STIs, sexually transmitted infections. And then she denied all of the following. The dyspareunia is pain with intercourse, and then bowel changes, obviously, you know, did you have diarrhea, constipation, anything like that? So denied all of that. Okay, physical exam, what you examine on the patient. General, she's non-toxic appearing, alert and oriented. The skin, normal, no rashes. Respiratory, normal. Cardiac, normal. Genitourinary, she declined like a vaginal exam, right? We do pelvic exams. Some patients will say they only want a female provider, so I often get patients sent from other clinics to do their pelvics on them, or if it's a, you know, GU kind of complaint. And the psych, mood, and everything was normal. What was abnormal was the abdominal exam. So her bowel sounds were great. You know, it wasn't hyperactive, meaning excessive bowel sounds indicating possible like a diarrhea, right, or gastroenteritis. And it wasn't absent, meaning like a bowel obstruction, right? You don't want your bowel sounds to be absent. That means you're not moving anything there. And she didn't have any CVA tenderness. So that's the costovertebral angle. It's on the back. It's basically right over the kidney. You put a hand on the patient's back and you kind of give a couple of like thumps like that, not super hard. You know, you're not trying to hurt the patient. But if they're having like kidney pain, or commonly with kidney stones, you get CVA tenderness, they'll feel it right away. But she didn't have any on either side. She was very, very tender to palpation. I mean, I barely touched her on the right lower quadrant. So if your abdomen is divided into quadrants, right? You just divide it into 4, the right lower side. right lower quadrant and pelvis. She was guarding, meaning her arm, like her hand was over it. She was constantly trying to keep me from pushing on it. She had a positive Robson sign, obturator, psoas, and McBurney's point tenderness. Does anybody have an idea of what this is?
Okay, so we do have a audience member in the chat saying that it might be appendicitis.
Yep, that's a good guess. Anything else?
Someone also said maybe kidney infection or possibility of kidney stones.
Yep. Those are all very good thoughts. Yep. So Robsing sign, if you guys are not familiar, so Robsing sign means palpating the left lower quadrant. So opposite of where she was in pain, you're palpating the left-hand side, and that causes pain on the right-hand side. McBurney's point. So if you guys mark where your belly button is, and then you go to the front of your pelvis, right? The top bone of your pelvis where you can feel it, go 2/3 from your belly button towards the pelvis. So a little closer to the pelvis, but that's where McBurney's point is. That's right over the appendix. And the obturator sign is pain on internal rotation of the thigh. So I have the patient lie on their back, and I just take their right foot and I turn it inward. So you're rotating the thigh inward, and that causes significant pain in the lower quadrant. The psoas sign, the patient lies on their left. So I just turn them onto their left, and then I hold their back still, and then I pull their right leg, keep it straight, their right leg, and I just pull it straight back, if you guys can get a visual of that. The alternative is you have a patient lie on the table for the psoas sign, have them lie on the table. You have them come all the way to the edge of the table on the right, to a point where their right leg is going to hang off the table. So their left side of the body stays on, right leg hangs off, and you just pull that right leg back. That's the alternative if if they can't turn onto their side. If any of these are positive, you're highly suspecting appendicitis. Yes, that's a good guess. Okay. Objective data. So this is the labs, right? The things that are objective, right? So this is her urinalysis. We did a dipstick in the urine. We have a machine that runs it, so we don't have to do it manually unless the machine doesn't work. But she did have some blood. Nothing too significant. Blood is seen with urinary tract infections too. Leukocytes, which is the white blood cells, plus or minus, so really not that much. Nitrites and leukocytes are the two bacterial indicators for an infection in the bladder, so like a UTI as we commonly know it. This is not the blood, okay, but this doesn't highly suggest UTI to me. It's not, the leukocytes, and that pain is just, that's out of proportion, right? That pain just doesn't make sense. And the bleeding, she had her period last week, so not really sure why she's bleeding. She said she was spotting for a couple of days, but her OB-GYN is monitoring it. She declined pregnancy, if you guys remember, right? She declined pregnancy to the MA. She declined pregnancy to me. Her pregnancy, she's positive for pregnancy. Her HCG is positive. Does anybody have any idea of what could be going on?
Okay, so we have an audience member who said maybe an ectopic pregnancy.
Okay. Anything else?
Nope, that's the only response we're getting. We're also had another member of the audience also saying the same thing.
Okay. Yep. Okay, good. So what are the possible diagnoses? When we say differential diagnoses, this is what you're taught in school. So based on the patient's presentation, the data that you have, your physical exam and their symptoms, right? What are the most likely diagnoses? And typically in your mind, especially in an urgent care setting, you want to think about what is going to be the most life-threatening to the least life-threatening, right? That's how you kind of work through it. So we start at the bottom. UTI is at the bottom of my list because that urinalysis doesn't show it. That pain is way out of proportion for a UTI. Appendicitis, yes. I mean, everything does point to appendicitis. Ovarian torsion, twisting of the ovaries. I mean, her pain is pretty significant, and it's hard to differentiate between appendicitis, ovarian torsion, a cyst, and an ectopic pregnancy because everything is in the same location, right? An ectopic pregnancy is one that plants outside of the uterus, most commonly in the fallopian tube. That's all going to be in the same area. I don't have, you know, unlimited imaging in the urgent care, right, to decide this. So these are my top 5 differentials. A ruptured ectopic pregnancy was what I was thinking this was, because she's bleeding, she's had the spotting going on, she is positive, she has a positive pregnancy test, and her urine has a little bit of blood in it, but that blood is likely coming from the vagina, not from her bladder. So the next decision, and this is the most important that I was talking about earlier, is the patient stable, and what is the next step, right? What does the patient needs to do? In this case, she needs to go to the emergency room. My job is to determine, can I treat her, send her home, and then have her follow up, or does she need to go to the ER? I think she needs to go to the ER, because if this is an ectopic pregnancy that's ruptured, she could continue just bleeding into her abdomen, if that's what's happening, if that's what's causing this bleeding. Hard to say without any imaging, though. So I advise her to go to the ER. We always, if somebody has to go to the emergency room, I tell patients to take an ambulance. If they decline, you just document. You can't force a patient to take it. So same thing, I offered it to her. Her mom was with her, so she said she would rather have her mom take her. And you know, you just talk to them about the risks, that if something does happen en route, just understand that you could have a loss of life, right? I mean, nothing else you can do about it, but you have to make sure your patient is well informed. So yeah, she ended up having an ectopic pregnancy. So what's an ectopic pregnancy? Normal pregnancy. Fertilized egg implants on the uterine wall, right? About 300 million sperm enters the vagina during intercourse and ejaculation. So some of them flow out, or they'll die in an acidic environment. Some sperm passes through the cervix into the uterus. So right here, so right, it comes, those sperm's going to come through here. Some of it's going to make it through the cervix. And then the uterus destroys a lot of the sperm because it recognizes it as foreign bodies. So the uterus itself destroys many of the sperm. Half of the sperm travel to the fallopian tube with an unfertilized egg from the uterus. And then a few dozen of the original sperm are going to remain by the time they reach the egg. So they're going to travel from the uterus sperm to the fertilized, or to the fallopian tube. And then the sperm is going to burrow into the egg. The first sperm to make contact will fertilize. So in an ectopic pregnancy, what happens is the fertilized egg implants elsewhere. The fallopian tube is the most common, but it can implant in the cervix, the ovaries, or the abdomen even. The embryo develops and grows in areas that aren't meant to strain, right? The uterus, you guys can imagine a 9 months, like with the uterus, you can imagine how elastic the uterus is, right? Every female organ is not that elastic. A fallopian tube is not that elastic. Ovaries are not that elastic, right? So you're not supposed to have this kind of growth in any of those other areas. But usually with ectopic pregnancy, it's detected in the first trimester because of the symptoms. Can be life-threatening though if it's undetected, because the tube can burst, leading to internal bleeding. And if that's caught in time, that's good, and we can treat it, the best we can. But if it's not, that can cause death also. So what happened to my patient? So she had an ultrasound, of course, in the emergency room. No intrauterine pregnancy, meaning they knew she was positive, but she didn't have any intrauterine pregnancy. They didn't see anything in the uterus. So then they went on to a CT scan. CT scan showed hemiperitoneum, so showed some blood in the abdominal cavity, but her appendix was completely normal. There was a 2-point decrease in her hemoglobin. So she had some blood loss, which is indicative of a hemorrhage, right? Because we don't even know how long this started. She's been spotting for 2 weeks. So she's been slowly bleeding for 2 weeks. And one of those weeks, obviously, she had her period, but the spotting outside of that isn't normal. She had an exploratory laparoscopy. So the reason they do this is because it's inconclusive between the images. They can't really detect where the bleeding is coming from. So they did that, and they confirmed that it was a ruptured ectopic pregnancy. So her fallopian tube on the right had burst, and that's what was causing that extreme pain and that bleeding. She had right-sided salpingectomy as a life-saving measure, because you're going to keep bleeding out. So she did have her tube removed on the right-hand side. Doesn't mean she won't get pregnant. It might be a little bit harder for her, but she still has her left side, so she can still get pregnant. She was discharged after a 12-hour observation and was advised to follow up with her OBGYN outpatient. The products of conception will continue to shed for some time, so she'll lose some tissue through the vagina over some time. And then she came to the clinic 5 days after her procedure, and she was just really grateful. And this is something that we don't always get, but it's something I put in here to show you guys, like it's always nice to have those reminders, right, that what you're doing, like, because this was a really hard case for me. I mean, being close to her age, it wasn't easy to say, you know, this is what it might be, because you do want to tell your patient because you want them to be prepared, right? But PA school, we learn how to deliver some bad news, but you're never ready for it when it's the time. So this is one of my favorite and least favorite cases. It's one of the ones closest to my heart because I could sympathize. I could empathize with her, right? But she's doing well now, which is the most important thing. So treatment options in general for an ectopic pregnancy: surgery, just in this case, right? Ectopic pregnancy, you have a rupture of the tube, hemodynamic instability, continuous drop in that hemoglobin, right? Losing blood. They're not just going to say, okay, let me just give you some medication that'll help kind of terminate the pregnancy. No, they're going to need to do surgical intervention there. Intraperitoneal bleeding, what she had too, bleeding into the peritoneum. Non-surgical options, if you don't have an intrauterine pregnancy, if you but you can't have any of the other stuff with that. Methotrexate is a pill that you take, so that can be administered to terminate a pregnancy. Abdominal pain, but it depends on the degree. Like in her case, that would have never been an option for her, the non-surgical way. And then confirmed or suspected ectopic pregnancy, of course. So those are treatment options. So the next random cases, I can take, we can do either one. We can either do all these random cases first. These are just quick. They're not like lengthy case studies, just some stuff I wanted to share with you guys. But we can either do questions about my patient, or I can go through these and then we can do questions at the end. Does anybody have a preference?
Yes, so we do have enough time for the cases that you're going to present in a few minutes, and then we will ask the questions towards the end, if that's okay with you.
Yep, that's totally fine. Yep. So random cases. So if you think you're having a bad day, you at least weren't this guy. This was a 16-year-old. So where I work in the urgent care, they have boats and stuff in the back, and he was just there working on a boat, and he walked around to the McDonald's in front of our clinic, stepped in the grass, and right in front of our clinic. There's been a lot of construction going on lately on the parking lot. And so yep, got this nail stuck in his foot. And this is why multiple views on an x-ray are super important, because the one on the right makes you think it's completely under the skin. And then you do a complete lateral view and you realize part of it's sticking out. I could easily see it. So what do you do in this case? So yeah, he was walking barefoot, obviously, and this went into his foot. And I had to lecture him because he came into the clinic barefoot too. He didn't put shoes on even after that. So he came in, we updated his tetanus, right? Old rusty nail, you guys probably know about that. And then you just inject lidocaine, so 2% lidocaine. That's honestly the hardest part, is that the numbing, because those injections, when you put the needle in, needles, if you're tolerant with needles, those don't hurt as bad. But when you push the lidocaine in, that causes the pain. So just numbed him all the way around. And I mean, it was a lot quicker than I thought it would be. But all my staff wanted to see it, so he had an audience of like 4 people for this. But yeah, quick removal. And then again, going back to the bad news, how do you deliver bad news? This one, I had a patient back in, I think it was like September of last year. She came in because she had this like lump in her breast for like a couple of years, and it was fine. Her primary care told her to just monitor it. She hadn't had a mammogram in 5 years, and her sister had a history of breast cancer. And so she came in because she said, it's getting like a slightly tender, but she was like, it actually came to the surface. So it's been going on for 2 years. Over the last 2 months, it kind of came to the surface, but then over the weekend, she said like it was kind of oozing like this. So as soon as I looked at it, like she was not tender at all. It wasn't warm, it wasn't hot, so it's not infectious, even though it looks like infection, right? This is called a fungating breast cancer. So 2 years she had it under her breast, so it's likely that it's pretty progressed. She had some lymph node involvement as well. So this patient, it ended up being breast cancer, and she obviously, you know, came into an urgent care on a Monday, and by like Thursday or Friday of that week, she was in surgery and had a, you know, an oncologist, a breast surgeon. I mean, it's big, right? I mean, you come in because you think it's just infected, and now you have this whole other team of healthcare providers. And so you're never ready to deliver bad news, is my point. And you never want to sugarcoat it. You know, you have to be gentle, you know, this is not a time to be straightforward and super like, you know, abrasive, but they also need to understand like, hey, this is what I'm thinking. Because she said that she would just call her OB-GYN. I offered to biopsy it. She didn't want to have it biopsied by anybody other than a breast surgeon. So I said, okay, what if you go to my supervising doc and he biopsies it? And she said, no, I want a breast surgeon to do it. I said, okay. So for my own liability and protecting myself, I called and I scheduled her ultrasound and her biopsy. So she had an ultrasound on Wednesday morning. The biopsy was an hour after the ultrasound. So at least I knew that she was given this information in the clinic and that she was going to have it taken care of, because it was just kind of like not watched, right, for 2 years. And so it was really important to me to make sure that this thing gets watched. And she was not excited, obviously, and it's hard because you try to do the best you can, but this was another hard case, one of my hardest. And she was a little older though. She was 50 or 60 years old. So kid, this was a 5-year-old child, hoverboard, fell off the hoverboard, landed on his right elbow, landed directly on the right elbow. First child came in, couldn't move his arm. You could see the bony deformity. So where it's like not right here, like this on this little bump here. You don't normally have that in kids, normally straight, but you could feel it. I mean, I could feel that this was fractured. It was just a matter of x-raying to see what degree. We don't learn how to do x-rays in PA school, by the way. I learned this on the job. My urgent care has x-ray. We have x-ray techs some days. Most days we do not, though, and it's usually at the busier clinics. So my clinic doesn't really ever have an x-ray tech. So I learned to do it. If I'm not comfortable with certain x-rays, like I'm not comfortable with the spine, for example, I'll send them to the imaging location, the imaging center, and have it done there. And then I'll call the patient with the results. Yeah, elbow x-ray. So in this case, I'm sending the patient right away to the orthopedic surgeon. So I sent him to the children's hospital. Somehow all of these like intense cases happen at the end of the day. This was also at like 7 o'clock. So ended up sending him. The child went into surgery that same night to hopefully preserve function and sensation in the arm there. The kid, though, he was great. I mean, he went through the entire x-ray series. Otherwise, being able to get even 2 views like this, is you can imagine with the pain that he was probably in, right, with this break, and being able to sit through x-rays with this kind of injury is incredible. So yeah, kids are definitely some of my most resilient patients. The mom was a mess, understandably, because it was the first time he'd had this kind of injury, but he was great. Surfing in Hawaii. So this one, yep, this is a fin of a surfboard. This is on the calf, the back of the calf. This is not uncommon. I was trying to find one that I've had that's even worse than this. You do the best you can do, right? Just close it. Like, I didn't like this job because I didn't like this like bubbling here, but without it, with all this gap here and that missing skin, there was just no way. So he had some bubbling there, but sometimes like when you put lidocaine in, so you're going to inject, same thing, you inject the numbing all the way around this area. When you put the lidocaine in, that also causes some of that swelling. So a lot of this is going to be down like at the 24 hours or so after. Some of this is will have settled down. And then there's areas here where like there's just missing skin in the middle. So you do your best to close it, and it's still better than that. But yeah, this was pretty gnarly one. There's some open skin right there too. But yeah, surfing in Hawaii, bread and butter of what I do when it comes to lacerations. It's 9 out of 10 of them are surf injuries, because my clinic is next to a beach called Sandy's, and Sandy's is it's notorious for their surf injuries because the waves are always intense. So yeah, but that's another one. I think that might be my last one. Oh yeah, and then this is how you can reach out to me if you do have any questions or anything that I don't get to here. available on Instagram, and then by email. I'm always up for answering questions and helping out. I'm obviously more knowledgeable with the PA profession than any other healthcare profession, but you know, I'm certainly open to helping you out with anything you may need help with. So if you have any questions, definitely just let me know.
Okay, so thank you so much, Dr. Patel, for your presentation. I'm gonna ask some of the case questions first, and then we can go on to the more general questions. So the first question we have over here is, was the injection solution a lidocaine epinephrine combination or just lidocaine?
Just lidocaine. So you can use, in the bigger areas, you can use lido with epi. Epi is a vasoconstrictor, right? So you can use lidocaine and epi, but in the so the ones that I did, I could have used them, but usually in the tips, like in the scalp or like fingertips, toes, stuff like that, you don't want to do epi because you don't want to constrict the blood flow there. So I just do lidocaine. Most of the time I just do lido, even in the toes and all of that too. But if they're on blood thinners, then I'll do epinephrine with it, right? Because the lido is going to make them bleed a little bit, and the epi will work against that.
Okay, thank you so much. So another question we have over here, you did mention you do some of the x-rays for your clinic. So were you certified to give x-rays?
No. So that was another thing that was on the job. And that also, you have to look at the state laws as well. In Hawaii, the state law doesn't prevent like a medical provider from shooting x-rays.
Okay.
And that's the reason we're able to do it. But some states, I'm sure, like don't allow it. And ultimately, it's going to come down to the technique. Like sometimes when I first started, oh my gosh, if I had pictures of my old chest x-rays, like that would be the perfect like embarrassment, because they were awful. Like my technique was awful. And when the radiologist, we send all of our x-rays to, because I do a preliminary reading. To me, obviously those x-rays, like there's a nail there, there's a broken arm there, but all of our x-rays go to the radiologist, who then sends us the final report. And sometimes in the radiology reports, like when I initially started doing chest x-ray and rib x-rays, they would be like, oh yeah, poor technique or motion or over penetrated, under penetrated. And I'm like, got it, I'll just send them to you guys. Like, you know, and so yeah, you're not trained to do it, but I do tell patients like the chest x-rays, that's totally fine. Ribs just never worked for me. So for ribs, I always send them out. But I tell patients, you know, the reason I'm sending you out is because if you do it here, there's a good chance you're going to have it redone. And that's just double the radiation for nothing. And so, you know, if they're really adamant that they just absolutely want it there, I just tell them, you know, you might have to come back in, or we might end up sending you there to have it redone, and they're okay with it.
Okay, thank you. So, okay, another question we have over here from one of our audience members is PA residency longer for subspecializing, or are you automatically qualified for any specialization you want to apply to work in after you graduate? And what does continued education look like for PAs?
Yeah, so that's a really good question. The residency thing is a big thing right now. So PA residencies are out there, if you've seen them. So if you're going to end up, I would say the most saturated fields for PAs: primary care, emergency medicine, urgent care, ortho, and dermatology, I would say. So with that being said, if you're wanting to end up in something like that, a residency may give you a leg up, because the residency program obviously is going to be a structured, rigorous program just in that one specialty, right? But if you are somebody like me who has broad interests, I get bored very easily. I mean, urgent care, I don't see myself leaving anytime soon, because I am getting a little bit of everything, which is what I love. But if you're somebody who does get bored very easily, just keep in mind that if you do the residency, to make it worth your while, you want to practice in that field for a while, right? Because as a resident, just like a medical resident, your pay is horrible. You're overworked, right? But the reward is that training. You're getting that training that nobody else, you know, has. So if it's between you and somebody else applying for the same emergency medicine job and you have the extra training, they're going to take you hands down. So that's where I think residency is beneficial. Hawaii, I want to say it's at Kaiser. I think it's at Kaiser. They have an ICU critical care residency. If I ever wanted to end up in an ICU, I mean, yes, they can hire you, you know, and you can be trained on the job if they're willing. Most ICU jobs need past, you know, previous experience. But if I ever wanted to end up in something like that, a residency is going to be golden for that, because that, one, it's going to be a better way into that job. And two, you also want to feel prepared and trained. The last time I put like a chest tube in or intubated a patient was a mannequin in PA school. So you don't want me to end up in the ICU without, that structured training. So yeah, and then continuing medical education, same as physicians. So we take our recertification exam every 10 years. My husband and I were lucky enough to get on the same cycle. My husband's a physician here. And so we were both doing that together. And then the continuing medical education, we have to do 100 credits of continuing medical education. So like this year, I attended the National PA Conference. It was virtual in May. And that alone gives you 150 credit hours once you complete everything that they have on there. And so you need to do that every 2 years, 100 credits every 2 years. So that's how we continue. So yeah, there are metrics. When you use, like, we have resources like Dynamed or UpToDate, like good medical resources that we go to for like things that we are not familiar with. Like it's like our Google, right? For everything that's reliable with medical. It's not WebMD, right? And so even when you use those like UpToDate, when you log into UpToDate, every time you search something in UpToDate, it's like a quarter, it's like 0.25 credits or 0.5 or 1 credit, depending on the complexity of what you're searching on there and using. So UpToDate also keeps track of that. So you earn by doing that too, because you're learning, right? The whole point is you have to read and learn whatever you're looking for.
Okay, wonderful. That sounds really, really interesting. Thank you so much for that. So another question we have from PA school is, do they train you in PA school on delivering bad news? If so, what were the main points? Also, are providers only allowed to give bad news? Yeah, or can nurses or ER techs give bad news as well?
It's going to be providers. Any medical advice that you're going to send the patient home with has to come from a licensed medical provider. So it is going to be just from a provider. Nurse may be an exception to a certain extent, but I don't really know about the nursing, but anybody other than nursing, other than like an RN, I would question. And the reason is it's just not coming from a licensed medical provider, right? But even nurses, I'm not sure about that. Yes, they do teach you how to deliver bad news. The way that I messed this up in PA school when we were practicing was I was basically trying to distract the person. So during my PA school interview, basically it was MMI, and one of the things was about delivering bad news. And when I was delivering the bad news, I was like asking about their family and asking about, like, I thought distracting them would be helpful to, like, make sure they're in a good state of mind before I tell them. But that's not what they tell you in school. In school, they teach you that, with the bad news, make sure you're empathetic, compassionate, be patient, right? Let them digest whatever it is you're telling them, right? They're not coming in expecting to hear whatever you're about to tell them. So let them digest it. And just be upfront and be straightforward with them, and help them understand that, there are, treatment options, or what is the next step, like talk them through it. But you always want to give time for those patients. So if I was in like a primary care setting where I knew I was going to be delivering bad news based on some tests or something like that, I would make sure that appointment was scheduled for like an hour block or something like that, so that's what I mean. And so delivering bad news, I mean, the main points would be just being straightforward and being empathy, delivering with empathy and compassion.
Okay. So another question we have over here is, how much importance is placed on research experience for PA school?
That's a good question. So my research experience personally, I only had one interview where my research experience came up. And that was only because the faculty member was interested in research as well. Some programs that are very research based, right, or they're attached to like a big research center or something like that, or affiliated with that, they may place more emphasis on it. And that's something that the website should tell you, for every individual program. If they highly, appreciate or value research, that should be on there. But in general, I would say the patient care experience, like that paid hands-on experience, is valued a lot more.
Okay, thank you. Okay, so another question we have over here says, can you recommend any organizations which should be joining as an undergrad for PA school that don't already require a PA degree?
Oh yeah, American Academy of Physician Assistants. Depending on what state you're in, it's going to be your state's chapter. So like FAPA was the one in Florida where I went to PA school. Florida Academy of Physician Assistants. In Hawaii, it's HAPA, Hawaii Academy of Physician Assistants. So find your state one, and then American Academy is AAPA. And that there's a lot of information for students, pre-PA students, and anyone just considering the field too. So both of those are really good, yeah, to join. And it's cheaper to join as a student than it is as a provider.
Okay, great. That's really, really interesting. Thank you so much. So okay, another question that we have over here is, would you recommend doing a pre-PA post-baccalaureate program after undergrad to increase the chances of getting into PA school? Or would it be better to finish taking the prerequisites classes and obtaining as many PCE hours as possible beyond the minimum required before applying?
I would say the latter. I mean, everybody's goal is different though, right? I mean, some people say, I just want to get through undergrad and then maybe take a gap year and then I'll do the prereqs and then I'll apply. But if you're somebody who does want to do everything and just straight out of undergrad wants to go to PA school and just kind of like get your career started, if that's what drives you, then I would say the latter, right? But then just know that you are gonna like, if you choose to do a non-science degree, you will be putting in more work, because for me, my biology degree covered the majority of my PA school prerequisites, right? So I didn't have to like work too hard outside of that or spread myself too thin academically with extra coursework, because I needed the class to graduate with my bachelor's in bio and I also needed it for PA school. So it served a dual function. So, but with that being said, do I recommend a bio degree? I mean, maybe it's definitely helpful, right? It gives you a good foundation, but the prerequisite courses are what give you that foundation out of the bio degree. So is it necessary to do the bio degree? No. So I say follow your passion in undergrad, right? If you have a passion in English, for English and writing, pursue your degree in that and just do the prereqs. It might mean that over undergrad you add in extra science classes, so you're going to be taking more courses. It also might mean that you're going to be taking summer classes, right? Just to like make sure you're ahead of it. But the patient care experience, you should gain as many hours as of shadowing in patient care. I tell all of my mentees that you guys should start early. Start your first year of undergrad, because that's probably the biggest mistake that I see students make when it comes to the non-academic side of things, is waiting until third year and saying, okay, yeah, I'm going to start finding something now. I mean, as a pharmacy tech at that time, I didn't know I wanted to be a PA, but because I started in undergrad and I could only work part-time outside of like, whatever school would allow me to work, outside of studying, I only worked, I mean, some weeks I only worked like 15 or 20 hours, but by the time I was applying, I had like 4,000 or 5,000 hours because I had started so early. So that allows you to do that. What happens is you get to your third year, one, you're hoping to find a job, and two, you're probably going to end up having to work full time, if you otherwise wouldn't have to, just to get those hours, right? So it just becomes more stressful. But then, like, as you progress in undergrad gets more stressful too, right? As you're taking the upper level courses in whatever your field is. So just keep that in mind. I would start early.
Okay, wonderful advice. I definitely agree. So another question is, what's the best PCE without having a certification?
That's a good question. That's one I get pretty commonly. So EMT, you're going to have to be certified, right? Working on the ambulance, like you will have to get a certification. Medical assistant is always one that comes up, and not every place of employment is looking for a certified MA. That's a very common misconception. Not every place is looking for a certified MA. Here's the thing, as certified MA, it's twofold. It's catch-22. It makes you more marketable. If you are a certified MA, it makes you more marketable, but you're investing the money in that certification, right? For something that at some point is going to have an end because you're working towards some other higher goal, right? In medicine. That's one side of it. The other side is the practice is going to find a certified MA attractive, but the practice also has to pay a certified MA more than a non-certified MA. So with that being said, there's benefits on both sides to having certification and then also not having certification, right? I will tell you, my urgent care clinics, it changed a little bit because the hospital system bought the clinic, but we still have MAs that are not certified and they're working towards certification. But what's happening is when they were hired, they weren't certified, but now the hospital is making everybody get certified. So they're just paying for the certification and having them go through it, and they're paying for the tests and all of that. So like a lot of independent practices, like small practices, private practices, a lot of those probably would not require the certification for MAs. And that's just one that comes to mind. You know, that's always up for debate. Medical scribes, there's no certification. You just have to apply and then they train you on the job. There's extensive training there. Pharmacy technician, I did become certified, but I was also a tech for like 3 years before I was like, you know what, I should just become certified in this. I don't know why I'm not. And so I just did it just to do it, but I was hired uncertified and I wasn't certified for the first 3 years. So, and that could have changed. I feel like pharmacy tech, I feel like the certification significantly helps as far as your knowledge. And so I wouldn't be surprised if pharm techs require certification now.
Okay, thank you. Yeah, they actually do. I wanted to work on pharmacy as a pharmacy technician, but they do require a
Yeah.
certification
Yeah,
right now.
that's
So yeah, it's been quite hard.
yeah, that's hard.
Okay, so another question we have over here. Do you consider your profession as more diverse and inclusive of minorities than other medical professions?
You know, I don't think the PA profession is as diverse as it could be. I really don't. That's the short answer. I definitely think we can increase awareness and diversity in all facets. I mean, diversity has a lot of different meanings to it. It's not just cultural background or orientation or, language, whatever it may be, race, but I do think that AAPA is making an effort to increase diversity. And so I do think that that is something that will help, of course, going forward. But yeah, it's for me, it's a little bit hard because one, you are a PA, so here having to explain Hawaii, one doesn't really have a lot of PAs, so having to explain what your role is in general, people just already don't know, right? But two, me being of my skin color here, a lot of the locals are my skin color. So people mistaken me as a local all the time. So here I don't have that issue, and I've only practiced here. So I can't speak for, eventually we'll be on the mainland. I can't speak for what will happen when we go to the mainland. I do think I'll probably have some more challenges in that sense, but here I feel like I blend in just fine. But as far as the profession is concerned, the profession is not that diverse. And that goes back to diversity in so many meanings. One of those things being get out there and learn a new language, right? So that you can communicate and cross language barriers with patients, right? Because that's a huge barrier to healthcare, right? Is the language. And so, yeah, but compared to even other professions, I mean, there are people of color in every profession, like medical profession out there, but that doesn't mean that we are diverse to an extent that we could be. I definitely think there's still work to do. Yeah.
Okay, thank you. Thank you so much for sharing that. Do you have any ideas of how practicing medicine might change in the future? How healthcare as a whole?
Um, I think PA, and again, this might be biased, but there's a lot backing it. I do think PA, the profession's been growing over the last several years. I think it's going to continue growing. It's more affordable, right? Because we don't we don't cost what a physician costs. We can't do everything that a physician can do, but we can do a good amount of what the physician can do. And so I do think that to bring down healthcare costs, I think advanced practice providers, PAs, and even nurse practitioners. I mean, I think between the two professions, I think that's going to continue growing with healthcare. A lot of healthcare is going to telemedicine, right? We have a lot of like even pharmacies, there's like dispensaries now with medications and things like that, right? Amazon, I think, has like a pharmacy now. And so a lot's changing, but it's never gonna, you're not gonna ever replace like the medical providers, physicians, nurse practitioners, PAs, because you're always going to need somebody to place hands on somebody, on a patient, right? That can't be replaced by a machine altogether, in my opinion. As technology changes, I might be proven wrong, right? But I do think that this is a growing industry. I hope that we're able to, I mean, I think one of the biggest things I'm passionate about is just delivering care to underserved populations, because in Hawaii especially, we see that a lot. There's a lot of underserved communities here. And that's one thing that we definitely need, is a more global accessibility to healthcare. So I'm hoping that's what we're working towards.
I really, really hope so too. So what do you think the impact of changing from physician assistant to physician associate means?
I think that, I mean, the word assistant not being there, I think, yeah, now people may not think that you're just, you know, like the physician's assistant, like following the doctor around with the clipboard, right? However, a physician associate, I do think that describes a little more, you know, it's a little more accurate as far as what we do, and it might prevent some misunderstanding. But here's the thing, you're always going to have that population of, you know, baby boomers, the older population in general, who just still doesn't know what you are. You can be a physician assistant, you can be a physician associate, but if you're anything other than a physician, they're not going to know what you are. I mean, that's just what it is, right? I've had patients walk out on me because the medical assistant says, hey, okay, the PA will be right in with you. And they're like, what's a PA? And then the medical assistants, like, I've trained them for what to say and like how to explain this to patients, at least before I'm able to get in, right? And some patients will like leave because outside the MAs will tell them, like, you know, let her talk to you about her role and this and that, but this is what, you know, this is what she is. And some patients will just leave. I've had a pharmacist tell me that she was asking me if I knew what triamcinolone was, which is like steroid creams 101. And I said, yeah, I know what that is. You know, as a tech, I knew that. And as a PA, I definitely know. And she's like, okay, yeah, I mean, I'm already here, so I'll just let you look at it, but I'll just go to my primary care for a second opinion. I mean, literally. And it's hard as a provider of any sort, to go through the rest of that encounter not feeling frustrated that, you know what, my effort is still going to go to waste because you're going to go somewhere else anyway. So, but you know, you're here to serve people. It is definitely a service industry, and so you are here to do the best you can do and provide the best care you can, despite whether somebody understands your title or not. And to me, physician assistant to physician associate, I understand why the push was there for that. But me personally, it doesn't change my role. I haven't all of a sudden found this new role within my profession. I am still the same person and the same provider I've always been. So, you know, we're talking about a broad understanding, but, you know, the ones that want to believe and understand your role will do it. And the ones that don't want to won't do it, no matter what title you have, you know.
Oh yeah, I do completely understand what you mean. So was there anything you did not expect when going into PA?
Um, yeah, I didn't expect to have a hard time finding a job in Hawaii. I mean, well, I think all of my colleagues, my classmates had jobs right out of school, and the offers that I got were all during my rotations in Florida or Georgia. And so I couldn't take any of them because my husband was here for residency. So when I moved here, I started from scratch. I was almost the last one to take my boards because the first available date was in June and we graduated end of March. So I didn't expect that. I didn't, and this is more Hawaii, obviously, but I waited like 6 months for my first job as a result of that. And what did I not expect as a PA? I didn't expect to have to explain myself as much as I am doing, as far as like my role, you know, just that, which is why like this push for the name change, I understand why, because I've dealt with it many, many times. But again, I do think the state of Hawaii is partially, you know, it's part of that because there's just not an awareness. I mean, our first PA program here just opened last year. And so I think that's going to change a lot. Yeah, I think the awareness of the PA profession is going to increase now with that PA program graduating providers. And that PA program places a heavy emphasis on people who are tied to the islands. So you have to be tied to the state of Hawaii. They want people that are going to stay and practice here, not just, students that want to come here, have a Hawaiian, adventure for a couple of years and then go back and take their skills elsewhere, because the islands definitely need the care. So, but yeah, I think the biggest challenge that I've had is just like my role. And when you're in PA school, they tell you that, right? I mean, it's nothing new about the profession. You know that you're going to have to explain yourself. A doctor never has to explain their role. Everybody knows what a doctor is. Everybody knows what a nurse is, right? But the PA, you already knew that you have to, explain it, but then you move to a place that has like a horrible, like, there's just a huge lack, not a horrible, but there's a huge lack in awareness of the PA profession, and that I didn't expect. And so that's probably been my biggest challenge, is just the degree of how much I'm having to explain my role.
Okay, thank you. Thank you so much for sharing that with us. I really, really, really appreciate it. So did you ever face any doubts or not have any support from your family or friends while on your path to becoming a PA?
That's a good question. I get this one too. So when I was applying to PA school, like my parents like didn't know what a PA was, right? Like my whole life, we'd only ever seen a physician, like pediatrician to their current like family medicine doc. We'd only ever seen a physician. And so my dad was like, why are you doing the PA route? Like, why don't you just go all the way and become a physician? And that's a very common like thinking, right? And it's not the right thing to think, but it's a common thinking amongst people who don't know. And so, but what I did is I just used it as motivation. Every time he asked me why I was applying to PA school, or like, said that I should do this, or that, I would just add another school to my list. So I just used it as my motivation to move closer towards the physician assistant profession. Yeah. So that's how I dealt with it. He was the only one, but he wasn't even like not supportive. He just didn't understand like why I was doing PA and not even thinking about, the physician route.
Okay, I love that. So for our final question over here, is what kinds of qualities do you suggest indicate a good mentor or role model?
I think somebody who one, you have to be passionate about what you do. You have to to mentor, you have to be passionate about teaching too. So somebody who's willing to teach, who's willing to take the time and help you understand, this is where you are, this is where you want to be, and kind of like someone who's willing to just answer all those questions, because there's a lot of unknowns out there about especially, I mean, the field, yes, but if you've never, like, you don't have a family member who's gone through the PA application process, you don't have any family members that are PAs, like, it's hard to navigate it yourself. I mean, that was me, and there was a lot of mistakes that I made my first year applying that I learned from my second year, and so having someone who's at least been through the process, right? Because at the end of the day, you need somebody who wants your best interest, which anybody that wants to help will have that. But there's a difference between that, like just being a PA who's practicing, and then having a PA who's willing to teach. So I would say somebody who's a really, good communicator, somebody who can be honest with you and give you constructive criticism and feedback. And as a student, be able to take that, right? I mean, when I do my personal statements, like, sometimes like on paper, it doesn't sound great because I'm like, okay, you need to work on this. We've gone through this 3 times now, but like, that's me pushing you, and so just having that, I think that mutual understanding, just getting to know them.
Okay, I completely agree. And thank you so much again for sharing your thoughts and your experience. We do have, okay, so I'm gonna make this one the last question.
Oh yeah, totally fine. No worries.
So how many PA schools did you apply to, and how many would you recommend?
I think I applied to, I want to say like 10, maybe less than 10. But I broadly applied, and honestly, I could have even applied to more with my my second application. But I would recommend, I mean, it really just depends on your right, your statistics and what your overall application looks like. But I would recommend broadly applying, because here's the thing, you can be the best student that you've ever been. You could be, you know, great academically, have all this experience and whatnot, but there might be somebody who's better than you, right? There's always that chance. So keeping that in mind, what some students do is they'll apply super early, which is what I recommend. You should always apply early, no matter what. But they'll apply early, and then as they progress into the cycle, they'll just add on schools. You know, like maybe a month later, they'll add on more schools depending on what they've kind of gotten back that last month. Maybe they got rejections or whatever, or they already got accepted, and then they're not going to add any more schools. So I think a good number of schools, I would say probably 10 to 12 is a good number of programs. And that's at minimum. I mean, there's hundreds of PA schools in the country, or yeah, like maybe in the hundreds. And so there's a broad chance of you getting in, but applying to PA school is also very expensive. So that's another reason that mentoring or just running it by somebody, an academic advisor, anybody, like let somebody look at your application objectively and say, okay, this is what I think you need to focus on. Because every program, like there are PA programs out there, like if you've gone through undergrad and you haven't performed your best, there are PA programs out there that say, you know, okay, we're going to take the GPA that this application automatically calculates, but we're also going to look at heavily at the last 60 credit hours, because we know that's you in your most recent academic years. That's you as a current student. That's not you 4 or 5 years ago in undergrad, right? As a freshman in undergrad, we're going to take the last 60 credit hours and we're going to base your GPA off of that. And usually when you know you're applying to PA school, most students end up doing a lot better towards the end, because either they're repeating classes or whatever it is. That last 60 hours usually ends up helping those students, especially the ones that maybe didn't do as well initially. So yeah, I think 10 to 12 schools is a good number.
Okay, thank you. So do take that into account, audience. Okay, so I'm gonna share my screen and we're gonna get ready for our wrap-up presentation. So once again, thank you so much, Dr. Patel, for joining us today, and for your wonderful presentation. I'm really sorry. I do think we all learned a lot, and I know that at least I did. So considering this, I would like to encourage everyone here to reflect on this session today. And there's 3 questions on the screen. So what brought you to the session today? What are 3 major takeaways you got from it? And what do you want to learn more about? You can, just answer these on paper or in the back of your mind, however works for you. But if you do answer these questions on paper, and even though it's not required, we encourage you to submit it to our website for publication of your hard work and to enhance your future applications. I would also like to mention once again that PreHealth Sharing is launching a research program that will allow students to connect with principal investigators as they conduct research in a variety of topics, fields, and locations. Once again, this program is 100% remote, which means you have the power to connect with anyone. So for more information, you can fill out the interest form that was sent in the chat below, and we will get back to you as soon as possible with any additional details you may have. If you want to learn more about PreHealth Shadowing and how to get involved in our program, we encourage you to visit our website. You can become an asynchronous volunteer to get certified hours through professional nominations, graphic design, and social media promotion. Also, we are accepting team member applications if you want to take on a more active role in PHS, to lead projects and initiatives to be up here with us. Once again, we are humbly asking that if you are financially able to donate, that you please consider doing so. It costs a lot to keep our program up and running and free to all of you. So if you're someone who can afford to, or if you know someone else who can, please support those who cannot by donating to our organization so everyone can continue to get the education they deserve. Otherwise, we simply ask you spread the word about PreHealth Shadowing to reach as many students as possible. Now, for the part we have all been waiting for, that is earning a digital certificate for your virtual shadowing hours from this session today. So the first thing you're going to do is go onto our website and find our professionals course pages. In this case, Dr. Patel's page. There you will be able to take our 10 quick 10 question multiple choice quiz based on the content from the session today. You will have 30 minutes to earn a 70% or higher to get your certificate. And we do know that sometimes technology can be difficult. So for this reason, we allow up to 2 attempts to take the assessment. But if you run into any other difficulties, please do not hesitate to contact us so we can help you guys out. To ensure that our website does not crash from a high influx of students, we do recommend waiting about 30 minutes to an hour approximately after the session to take the quiz, which will be open, and I want to highlight that indefinitely. And finally, once you have passed, you can click the Finish Course button at the bottom of the professionals page, and there you will be able to download your certificate verifying your virtual shadowing hours. If unfortunately you missed a part of this session or you want to go back and view other sessions to earn more certificates with verified virtual shadowing hours, you can go to our YouTube channel and watch our previous recordings. You can also find them via the professional pages on our website and take the post-shadowing assessments for these as well. Be sure to follow us on social media or subscribe to our email list for the latest updates on upcoming sessions and events. We're currently booked for every weekday through the rest of June for virtual shadowing sessions. So we definitely hope to see you guys over there. Once again, thank you all for joining us today. And please do stick around if you have any questions, and myself and other team members will be happy to answer them. The shadowing session is officially over, and I invite you all to log off. Have a wonderful day, evening, or night, depending on where you are.